Doctors. To get the session started, I would like Dr. Nivin to please unmute the mic.
Yes.
Yes, doctor, over to you.
Thank you.
Thank you, doctor.
Good afternoon to one and all on a Friday afternoon. So we're going to start the session on time, bang 2:30. So this is going to be on complicated cataracts and how we do phacoemulsification, as phacoemulsification has become a basic bread and butter for all ophthalmologists across the country. And to be talking on us, we have a great mix of the expert speakers, starting from the young dynamic Samresh to the most experienced Mohan Rajan sir across these things. So without any further delay, I think we'll start off the session so that we can take up any discussions or any questions that come along the way. So, sir, you want to say any few words before we start the session?
I think it's the third or fourth year we are doing this session together. Nivian, yes. Every time in AIOS we are doing this, and it's a very, very comprehensive course, I would say. Very useful with good take-home messages, very good faculty, very good videos, and every time something new comes up. And this time also, I'm sure the delegates will have something very, very useful to take home.
Thank you, sir.
Thank you very much, Nivian. Yeah.
So Samresh is going to talk to us on phacoemulsification and short and very long or myopic eyes. I know this has been a challenge for most surgeons because the chances of complications are very, very high in these cases. So that is why he's going to come up tell us all the tips and tricks on how we manage these cases. Over to you, Samresh.
Thanks a lot, Nivian. I hope I'm audible and clear. Again, thanks a lot for having me for this session again for the third or fourth time. And normally on an AIOS, I would look forward to seeing sir and madam and you, but I mean, we have to make do again for another year somehow. So this is the view from my terrace. I was just telling Nivian, Jaipur, I have a fort right opposite my hospital, so it looks really pretty in the evenings. Phacoemulsification in long and short eyes is like Niven said, not only difficult for early starters, but also difficult for very experienced surgeons, because a lot of things can go off track, and most surgeries are not dedicatedly designed for operating on these eyes. So I'm going to start with short eyes first, and then move my way into longer eyes later. So there are a few points to consider when you have a short eye. I'm just trying to, yeah. So there are very few points to consider. When the eyeball gets short, all the structures tend to get short except probably the lens. And that is what causes one of the problems in crowding. So you have a short axial length, you have a small cornea, you have a shallow anterior chamber, iris is bulged out. The lens is normal or larger in size, but it's definitely not smaller. And these eyes are predisposed to uveal effusions because of a lot of blood flowing through very small space. The more common thing compared to nanophthalmos, which is what we just discussed in this previous slide, this is classical nanophthalmos, where the entire eyeball gets short. But the more commonly seen problem in our clinical scenario is what is known as relative anterior microphthalmos, or RAM, which is what you would most likely experience in your practice as an operating surgeon. Now, what is RAM? RAM is another variation of a small eye where the anterior chamber depth is small, but behind the anterior chamber, behind the length, the axial length is a normal eye. So it's just a short anterior chamber. That's why relative anterior microphthalmos. So there's very less chances of having any uveal effusions or problems. But these eyes are a little more predisposed to corneal degeneration in terms of guttata and pseudoexfoliation. The other option, the other variant that you will get in your clinical practice, not as common, but not as RAM when it comes to cataract, but relatively common in normal population, is what is known as the exact opposite, which is a normal anterior chamber with a short axial length, which is a classical hyperopia that you see. These eyes, the only problem that you might face is IOL calculations, because most formulas are not catered to these eyes. But these eyes are not difficult to operate. When it comes to axial length determination, for all eyes, it's very critical, but it becomes even more critical for very long and short eyes, because small errors lead to large refractive problems. So my preferred go-to technique is an optical biometry. Whenever I get an opportunity to lay my hands on a swept source, that would be my preferred one. But if you don't have an optical biometry, I think the least one can do is go ahead and do an immersion biometry over a contact biometry, simply because you're measuring the visual axis of the patient and thereby more appropriate readings. My go-to formula for the last 2-3 years has become Barrett's, because Barrett for me works in all sorts of eyes, myopic, hyperopic, and normal eyes. The other formulas one can look at is Holiday and the Hill RBF formula, which are evolving formulas and give us fairly reliable readings as well. But no matter what I operate or what patient, I counsel 100% of these patients for residual refractive errors if they fall plus minus 2 standard deviations outside the normality range, because no matter how good I calculate and how enthusiastic the patient is, there's nothing one can do, because nothing is catered to these eyes to be precise. So this is a short, this is a small carotid anterior chamber, as you can see on a slit lamp with a dense cataract. And I brought about this case to show how things can go wrong. If you notice, this is the same patient showing a B scan, showing a thick choroidal thickening and the dense choroid. Over there, I would normally give mannitol to patients where I do suspect anything might be going wrong. I tend to use small incisions, and I try to avoid main incisions as much as possible. So my preferred technique, apart from doing a phaco for IA and for IOL implant, I would use bimanual or smaller incisions as much as possible. At all points in time, I would want to avoid an hypotony, because the moment you have an anterior chamber hypotony, the choroid will swell up. Then it may cause an expulsive bleed. And for this, my best viscoelastic in hand is a dispersive viscoelastic, which I'll just show. So this is just to show you, this is an old video from my institute, which I borrowed within larger incision. Notice how difficult it is to even put in the chopper, because there's absolutely no space. With the irrigation bottle height running at 100, there's literally no space. Needless to say, you're going to cause iris chafing in such eyes, because you'll have to, there is no possibility for you to protect these eyes. At least there wasn't at that point in time. So the best thing to do is to use viscoelastics, which are tools now in our hands to prevent damage from happening. My preferred viscoelastic is dispersive, in this case Viscoat. Viscoat is chondroitin sulfate. It's a heavy viscoelastic, heavy molecular weight, and like its word says, dispersive, it will sit like a paperweight and it will pull the iris back towards the posterior pole, and it will prevent it from prolapsing. So you can easily remove your instruments. Once that is done, again, like I said, it's important to understand that you have to deliver the energy right in the middle of the anterior chamber, but because there's no anterior chamber in this and there's no depth, there is bound to be corneal damage. So using viscoelastics, again, dispersive, using low energy. And notice how over here, I'm not using phaco to remove the nucleus as much as I'm using manual braking. So I'm basically trying to break down the nucleus physically as much as possible rather than using phaco energy, because manual breakdown of this nuclear fragment will cause less energy, thereby less corneal edema. So was the idea. But this is how the patient looks on a post-operative day, because there was literally no space, and despite all manual maneuvers, the damage had been done. Another case, I'm not going to show you, this is not because Dr. Sujata Madam is taking small pupil management. I'm just going to discuss that this is a extremely hyperopic eye, small anterior chamber and non-dilating pupil. So my first incision that I normally would do in an eye which has absolutely non-dilating, absolutely shallow anterior chamber is a side port incision using an MVR knife and not a main incision, because it gives me a very limited access to insert, like I inserted dispersive viscoelastic. Now, since this is a small eye, I decided to imply small pupil. I decided to put hooks to open up the pupil, because in a small eye, the moment you start doing a phaco, the fluid will find its way behind the iris and it will pull the iris up and cause tenting up of the iris, which is going to start plugging your incisions. So I tend to put hooks to tighten up this iris like a trampoline, and then I go ahead and do my surgery. My preferred technique for pupil dilatation in such eyes is Greischeber's hooks. Once I do the 4 hooks, then I do my incision. I'm not going to discuss this any further because it makes no, and then I go ahead and do a surgery like a routine surgery. One couple of small pointers: in a hyperopic eye, one would want to make a larger size rhexis than a normal eye, because these eyes are smaller. So the rhexis, what appears to you to be large, will turn out to be a little small when you put an IOL, you realize. But the most important thing, one of the most important steps is this: when you do a hydrodissection, be very sure that you slightly decompress it and don't overinflate the capsular bag, because it's already very tight. Just to show you, if you hydrate, if you do a hydrodissection, and if you have a small capsular rhexis and you don't decompress or you overinflate, you're going to push the entire lens anteriorly, and this is called a intraoperative capsular blockade, or an IOCV. And an IOCV in a hyperopic eye in a surgery or a small nanophthalmic eye can be absolutely lethal, because the posterior capsule can burst open because of the excessive pressure. So do a very gentle hydro in these eyes. Again, beware of the choroid, and that's why keep the eye inflated at all times and don't yank away your instruments. Be very gentle. Do a viscoelastic exchange before pulling out the instruments. Once the surgery is done, be very careful. Counsel these patients, because a lot of them will have amblyopias because they've never seen in their lives. Now, shifting gears from this to longer eyes, and I'm discussing fluid parameters for longer eyes because that is where the maximum impact of this is done. And by longer eyes, I mean high myopic eyes, staphylomatous eyes, post-RK eyes, or post-vitrectomized eyes. We did a study long back from our group, and we concluded that when you use higher parameters technically means a high bottle height, a high aspiration flow rate, high vacuum, and high energy in a myopic eye or normal eye, compared to lower parameters, you lead to more inflammation, which is visible as more corneal edema because you have to bring it anteriorly and you're causing so much more chatter and more anterior segment inflammation. We also measured the intraocular pressures inside the eye. This is again published by our group. And we found that, higher aspiration flow rates and high bottle height lead to higher IOP. And imagine in a myopic eye, which is already degenerate, and a high myop eye, if you put up the IOPs up to 85 millimeters of mercury, what's happening to the optic nerve and what's happening to the macula when the cells are already pretty degenerate and very, very fragile. So we have to be very, very careful when using myopic eyes. Don't increase the bottle height to abnormal levels and don't use very high flow rates and very high vacuums if you can avoid it. This is just to show you, this is on an infinity vision system where we are using a low flow rate, which is about 20, and a bottle height which does not exceed 60 millimeters of mercury. And notice that this is a graph where we have a transducer in the eye which is measuring the pressures, and look at how tranquil the graph is. Compare it to a high parameter graph. There we put the IOP to 80. We put the bottle height to 120 and increase the flow rate to 40. And notice how this graph jumps up and down, up and down. Every time there is an inflation deflation because of occlusion break, your whole thing goes up and down. And obviously these eyes are going to have problems later on. So this is just a comparative showing a turbulent graph with high parameters versus a stable static graph using low parameters. So how do you do that? You balance the input to the output. This is basics of phaco. So if you input low, you output less. So if you drop your bottle height, appropriately drop your vacuum and your flow rate so that there is an input-output balance and the chamber does not surge. And believe me, it will not surge. If you balance it right, it will not surge. But what is also important to understand that is not only the inflammation and all that, but high parameters influence the anterior vitreous phase and directly or indirectly influence the peripheral retina and can lead to breaks in the eyes as well. This is just to show you that we've put, this is a clinical experiment where we filled up the Burgess space with triamcinolone, and I'm just going from foot pedal 0 to foot pedal 1, which is no irrigation to irrigation. So as I do it, the whole thing moves back. Now I'm increasing the bottle height. And notice that when I increase the bottle height and appropriately, obviously increase the flow rate so as to compensate for it, notice the movement of the vitreous phase. Look at that. It goes all the way up and then it pushes all the way back, all the way. So every time you move up and down, it trampolines. And at some point in time, the anterior vitreous phase broke with an intact posterior capsule, and all this triamcinolone was in the mid-vitreous cavity. Just to suggest that if you use high parameters, you're going to break the barrier, natural barrier of the anterior vitreous phase, and this will lead to all inflammation, particularly in myopic eyes, going back posteriorly, and that leads to cystoid macular edemas, and all the trampolining can lead to retinal detachments in periphery and breaks in the periphery as well. So it's a great idea to monitor IOP throughout the procedure if you have an IOP-based system. If not, keep your bottle height low, and one understands that good chamber stability happens with good bottle height. Just one case to end this with, a myopic eye. To highlight the point, this is a myopic eye where RK has been done. I just wanted to show you that when I'm doing a phaco in this eye, it's a softish pupil. Notice my IOP is 20, which translates to a bottle height of 35. And this not only happens during sculpting, but my flow rate I've kept to 10. So 10 flow rate is a really slow flow rate. But notice the anterior chamber is completely dead stable. And once I have broken down the nucleus, I'm also doing a fragment removal. This is a Centurion system, but in any machine where you can put up a 40, 50, 60 IOP and a flow rate of 20, and you will not have a chamber flutter if your bottle height and your aspiration flow rate match. And you'll be able to take out this very, very smoothly without causing any fluctuations. The same thing, like I said, for a bimanual IA, my preferred is bimanual when it comes to myopic or hyperopic eyes. But again, my IOP is low, but my flow rate is also low to compensate so that there's no surge, and I'm able to take off the entire cortex quite efficiently. In these eyes are the ones where you're worried for anterior trampolining, but nothing will happen so long as your inflow and outflow match. The posterior capsule will stay at its place and not move. So just to summarize my very last 2 points, keep your parameters low for all eyes, small or big. Please handle your exercising properly. Slightly larger for a hyperopic or an ophthalmic eye, slightly smaller for a myopic eye. And bimanual is my preferred choice of instrumentation when it comes to any eye, but a compromised eye for sure. Thank you.
Well done.
Excellent, Samresh. I think you have covered all the salient features. Brilliant with the hypermetrope, the use of right viscoelastics and multiple times, and very less phaco energy because we have a very shallow anterior chamber. Mondran sir, anything different or any add-on things that you could suggest for hypermetropic?
I think Samresh did the topic, covered the topic very beautifully. For me, more than the myopic eyes, I'm a little apprehensive about doing hyperopic eyes, simply because you don't have the space there. And that is the reason why you are close to the corneal endothelium, and that is the reason why you have a problem of corneal edema postoperatively, and you have very little space in the anterior chamber to operate, especially in a non-ophthalmos. Okay, I burned my finger in one of the non-ophthalmos patients. One eye I did very well, the other eye had a choroidal hemorrhage, mainly because what Samresh said is very, very correct, not only in hyperopia but also in myopia. Please do not allow the chamber to collapse. Okay, every time you come out, you make sure that you inflate by means of viscoelastic, preferably something like a viscoat into the anterior chamber, so that the chamber does not collapse. The posterior capsule doesn't come forward, especially in a non-ophthalmos eye or hyperopic eye. What happens is there is a possibility of a uveal effusion. Once you have an uveal effusion, then you are in trouble, because everything will start coming out, and sometimes you can have a choroidal hemorrhage. Only thing is, the take-home message I want to give all the delegates is that when you have a sudden increase in the pressure in a hyperopic eye or non-ophthalmic eye, just don't blindly put a trocar and cannula and do a vitreous thing. Always do an indirect ophthalmoscopy. Make sure that you are not dealing with a choroidal hemorrhage. Okay, because sometimes you can have a choroidal hemorrhage without a choroidal infusion. Instead of infusion, you can have just a choroidal hemorrhage. And if you put a trocar and cannula, you are in trouble at that time. So I think this message is very, very important. Just because your eyeball is becoming tense and all that, okay, you can have other maneuvers, intraoperative mannitol. Sujata gives intraoperative Xylacort also, and this works wonderfully well to reduce the pressure. Wait for some time and till the pressure comes down, and then probably you can proceed with the surgery. But the most important points, I think, is covered very well. In myopia, the problem is what you call the fluid misdirection syndrome, because in the myopia, the zonules are all stretched and it's all very deep. So there's a possibility of the.
Thank you, Nivian, for this wonderful opportunity. And I think year after year, like Mohan said, we have been having a wonderful course, and I would like to thank Nivian for giving me this opportunity, and as well as the scientific committee. So the problems that we deal with, particularly in this era of post-COVID cataract surgery, we do see quite a lot of these patients now, because they've hardly come to us for over a year waiting for the COVID to settle down. So this is a scenario we see today. And what could be the common causes of small pupils? Long-term use of myotics, we don't see them anymore. Pseudo-exfoliation, yes. Prior iritis with synechiae, trauma, diabetes, and most importantly that we have to remember is improper mydriatic application. Poor dilatation can also be associated with advanced age, advanced nuclear sclerosis, and use of anti-prostrate agents. So if this is a syndrome called the intraoperative Propioidase syndrome, which is a separate entity, which is associated with the use of alpha-1 agonist, which results in the lack of tone of the dilator muscles of the iris, and comes to the triad of intraoperative signs such as iris billowing and floppiness, iris prolapse, and progressive meiosis of the pupil. And this is what we are commonly facing in patients who are on anti-prostrate. So these patients stop myotics before 48 hours before surgery, use long-acting mydriatics and cycloplegics. Topical NSAIDs might help, and plan for a good painless surgery by using either peribulbar or a subcutaneous block. So using a high-density super-cohesive viscoelastic also helps to keep the iris away. Pupil expanding devices are really a boon, and using low-flow parameters in vacuum and aspiration also helps to prevent the iris presenting into the probe. So these are some of the challenging situations. So you can see a very small pupil and a hard cataract, and this was in the era even before the hooks. So those of you who are just 25 or 26, this must have been, would have been 5 years old when we did this surgery. You can see I've just stretched the iris and gone ahead with the surgery. This can also be done even now. The only point now is when you stretch the iris, what can happen is the pupil becomes very floppy and it starts presenting to the phacoprobe. So it's important that you keep that in mind and use a super cohesive viscoelastic, and also never stretch towards your incision. So coming to the pupil stretching devices, we use iris hooks, pupil expansion rings, can use intracameral adrenaline, a high density viscoelastic. This is a classic case of a small pupil with pseudo exfoliation and a hard cataract. See, this pupil is not really small. Actually, you can do go ahead and do a normal phacoemulsification. An experienced surgeon can do it. But the only problem with these cases is the underlying zonular dialysis, zonulopathy, which is associated with pseudoexfoliation. So that might actually hinder you during the surgery. So it's always better to be safe than sorry. And then you go ahead with your pupil expanders using an iris hook. I also use only normally 4 hooks. There are people who use 5. And once you've done this, I like to stain the capsule because you can see that the cataract is quite dense. It's about grade 3 to grade 4. So you can just sweep the viscoelastic on the surface because you've already used a cohesive viscoelastic. You have to make sure that the surface is painted and then you go ahead with the rexes. In patients who have a very hard cataract, I would like to have a slightly larger rexes. The reason being that I don't want any stress on the SNUs, particularly cases like this pseudoexfoliation. It's worthwhile having a larger rexes than trying to manipulate your instruments within the small area. And then you do a gentle hydrodissection. And every time you decompress, I think Sandesh showed a beautiful example why it should be done. And then you go ahead with the chopping. My technique is for all type of cataracts, most of the cataracts I prefer to do a central trench followed by a direct chop. So the advantage of a central trench is it gives you some space for holding the nucleus. And the central chop is you continue to see the instruments, both the instruments, your phacoprobe as well as your chopper throughout. So you don't inadvertently hurt your anterior capsule. And my preferred choice of phacoemulsification machine is a Venturi machine because you don't need an occlusion for doing the phacoemulsification, particularly when you're during nucleus removal. And this gives an additional advantage because then you can just continue to do the phaco, just keeping your probe in the center as the nucleus pieces come forward. And there is less chance of iris presenting itself or non-target tissues coming into the probe. So my choice would be to go in for a Venturi machine. Of course, the active fluidics of Centurion and the stable fluidics, most of the machines are fantastic system where you can convert the peristaltic into Venturi. And here you can see that you can go ahead with just like how you do a normal cataract. Once you have a nice round pupil, nice stretched pupil, you can just go ahead and do your IA and then inject the lens. One point is before you remove the viscoelastic, you remove the iris hooks. That's very important. And then you go ahead and remove your viscoelastic because if you remove it before, then you might have difficulty in removing it later. So you remove it at this stage and then go ahead and wash and your this thing is complete. So the caveats are high phaco power, minimal manipulation of the bag, high density viscoelastic. You can use a soft shell technique. You can use an additional adrenaline BSS, which is epinephrine mixed with BSS, and always keep a CTR handy. This is again another patient of a small pupil, and just going to show this case, just to show that we can still go ahead with this type of the same size of the pupil, hard cataract, in fact, it's a mature cataract, and you can do a wonderful phacoemulsification even without any hooks. So this is what I'm see. You can just go ahead and do a nice round capsular rexus very close to the pupillary margin, do a gentle hydrodissection, do multiple quadrant hydrodissection, and every time you decompress the bag. That's a trick. If you don't decompress, then you might land up in trouble. And then you can start your phaco, use a soft shell technique so that you get the good advantage of both dispersive as well as cohesive viscoelastic for coating the endothelium as well as keeping the chamber stable. So see, here again, I made a small trench in the center and then I'm chopping the nucleus. Use a high phaco power, particularly in cataracts which are hard, so that you don't manipulate too much. You don't push the lens too much. That's very important, particularly youngsters. They have early surgeons who are just starting have a tendency to push the nucleus, so avoid that. And do a lateral separation, maybe a little less aggressive than what I'm doing here, because that can also destabilize the bag. So just keep your instrument right in the center, and you can complete the case very and eventually without any complications. You can see my phaco probe is in the capsular bag, not on the iris plane, not in the anterior chamber. So you're protecting the endothelium as well as doing an effective phaco without the pupil constricting. You can see how stable the entire pupil and entire the anterior chamber is throughout the surgery. And that's the advantage of using Venturi system, because you can control it. The other important thing is you can do a dual linear, so you can adjust your phaco setting as well as your vacuum setting just by using your foot switch. So the whole case is complete and the pupil has not become small. So this again is a point that you have to look into, and then you can go ahead and whenever you remove the last piece, whatever may be your machine, reduce all the parameters, because you don't want to have a problem right at the end. Then you can just go and do your this thing and complete the case. So next case I'm going to show you is a Malugin's ring. Malugin's ring is actually not my preferred choice because it's quite expensive. But this is this case I have done in a couple of cases, and this is one of the cases that I did some time back. So it is the advantages, you can insert it through a one single incision. You don't have to make multiple incisions. It's preloaded. It's made of polypropylene, and you can see it has got something like a safety pin hook. So it's very atraumatic to the pupil. That's one thing. And you can just inject it, even if you're not able to put the iris inside, doesn't matter. You can just inject it, and then you can gently tuck in the iris into the loops. And it's very atraumatic to the pupil. So the pupil becomes round even after you have removed it, which may not happen with the iris hook. Sometimes the iris hooks tend to tear the pupil, particularly the very rigid pupil. And you see the size of the pupil. You get a nice, large, round pupil. And the advantage again is that when you have a nice, large, round pupil, you can just do your phacoemulsification without any fear and just complete your case very effectively. And you can put the lens. See, I just want to complete this case just to show you how easily this Malugin's ring can be removed. And once you've injected the lens, before removing the viscoelastic, here again, you can unhook the Malugin's ring and use the same instrument through which you implanted it. There is a small hook or something like a finger, which will just grab it, and then you can just pull it out through the same incision. Now the newer versions can be done even through the side port. So and then you can just remove your viscoelastic. So coming to the last, but a very interesting thing is that this is one of our own Indian, but see, you can see this. I just want to emphasize on this and just going back on the video. So this is the patented simple design made by one of our Indian ophthalmologists. You can see there are sturdy flanges, flexible notches, and multiple tabs for holding. What is the advantage is it's extremely thin, very flexible, totally atraumatic, and it works wonderfully well in small pupil. And that's the greatest advantage. It can be inserted through a side port as well. So this again a great advantage. It's 1/10 of the thickness. See how flexible it is. And you can either introduce it just with the forceps if they have a BHEX forceps, which is recommended. And similarly, you inject the viscoelastic under the iris just to blow it up. And then there is a platform through which you can introduce it. And once you put it inside, you can gently tuck the iris all around. It's so flexible and so thin that the iris does not get damaged at all. So probably of all the three things that I've told you, this is probably the cheapest and the most atraumatic, and it gives you an adequate pupil size. So this is good enough for dealing with any cataract. It's about 6 millimeters, so you can go ahead and do 6.5 millimeters. I can complete the case very effectively without this thing. So this is the complicated cataract I've shown before. This is a case of floppy iris, small pupil, again an iris hook being used. So hypermature cataract. So these are conditions where you can use. The most important thing with the mature cataract is use a high density viscoelastic, decrease your fluidics, keep to the center. So when you're doing it without a hook, keep to the center and make sure that your surgical skill level is very high. So I'm just skipping on all these things. So remember that in a hard cataract, size of the pupil is relative. It all depends upon what the patient's surgeon skill is. And also look at the iris tissue properties. If a patient has an iris which is going to billow out or an IFIS, then it's better to use some hooks or rings. And finally, I'd like to emphasize on the anterior capsular staining because it's very important for visualization, a good hydrodissection to ensure good mobility of the nucleus. And nucleus management, chopping technique, and anterior or a karate chop, cold phaco technology. These are things that can actually match with interesting challenges in small pupils and hard cataracts. So challenges in small pupil and hard cataracts, proper mental preparation by the surgeon, and a few simple tricks. Thank you.
Thank you, ma'am. As said, I think they're all amazing surgeries, and you make all the super complicated cataracts, because for every surgeon, I think hard cataracts is a challenge, small pupil is a challenge, but managing small pupil with a hard cataract, you made it look very simple. So excellent. I have a small question, because when we started using hooks, we always found the difficulty of the iris tenting towards the section. But in your videos, they were all plain and it was not lifting up. So is there any tips that you can give on how to insert these iris hooks? Any angle?
See, the angle is that it's always better to make it a little bit towards inside, that is pointing inwards, not on the flat surface, so that it doesn't get lifted up. That's one thing. The other thing that other people do, which I watched, is they put a hook through the main port also.
Correct.
So or very close to the main port. So the advantage they say is that the pupils doesn't tent up. But somehow for me, I've never had this problem of pupil tenting up. I've seen some surgeons while they're entering, they catch hold of the iris and then produce an iridodialysis tear. I think it's the direction of the side port incisions that you make, particularly which is close to the incision on either side of the incision.
I make that one remark.
Down a little bit so that it doesn't lift up.
Okay.
Can I make one remark?
Yes, sir. And the positioning also, sir. Is there any particular sites at which is preferred to do the hooks?
On either side of the main incision, you put two, so that the iris doesn't come through the main port. Another thing is, when you put a stab incision, don't make it too small, don't make it too big. The problem is many times you make it very big because you use a side port knife to make the stab incision. So I found that Samresh's myringotomy knife is a good option. Only thing is, make it posterior limbal. Don't go anterior. If you make it corneal or anterior limbal, the iris will start tenting up. Okay? And if you put it posterior limbal, then there will be a tangential traction of the iris. And that is what required. And I feel that...
I want to interrupt here. See, it's more than that, the direction of the entry. So when you have an entry which is flat on the surface of the cornea, is more chance of it tenting up. So you go inwards, like you dip down when you enter.
That's what sir also telling me. Go a little more posterior and they're not coming too much into the cornea anterior.
That is, and also the direction through which you enter. If you make it parallel to the surface, then most likely the iris can be pulled up. So if you make it towards the nucleus.
Take Samresh's opinion. What is Samresh?
So I think for me, I use clear corneal incisions, but like Niven brought about the point of tenting up. My tenting up normally happens when I'm inserting the phaco probe, and that is why I'm worried the iris is there. So what I normally do is I go from the side port and I inject a blob of viscoelastic dispersive on the iris, and then I put my phaco probe inside. That's how I avoid the chafing at the subincisional side.
You can do that. You can put a cohesive viscoelastic on the iris, and then you enter. Then less chance of it getting into trouble.
And enter without irrigation. Enter without irrigation. And then after you go, for example, for all IFIS patients also, you enter without irrigation, and as soon as you enter the anterior chamber, you switch on the irrigation. Once you enter, similarly, while coming out also, make sure that you switch off the irrigation and come out of the eye. So that in that case, the iris doesn't come out of the eye, especially when you have an IFIS patient. So the important message I want to give, I think Sujata's talk is brilliant talk. I covered everything, but I want to give all the delegates is that please understand one thing. The small pupil is the biggest problem, okay? And all the complications of phacoemulsification related to small pupil, because you're not able to see well, you're not able to perform well. That is the biggest problem you're facing. So once you have a small pupil right in the beginning, especially when the patient is on Urimax or some other Flomax or something like that, this pupil is definitely going to come down on you during the surgery. Don't expect this pupil to dilate during the surgery. If it's going to be 6 millimeter, it is going to become 3 or 4 millimeter progressively. At that time, you find it difficult. So in the beginning itself, you make a decision. Okay, I'll put Mulligan ring, I'll put iris hooks, I'll put BX ring, whatever you're comfortable with. In the beginning of the surgery, you decide, so that you have a comfortable surgery throughout the thing and you'll have less incidence of complications. Take it from me, this is one of the things. We also analyzed the series of complications all related, most of them are related to the small pupils only, even in our postgraduates, residents.
So one more question to ma'am, like her chopping, you said, ma'am, you debulk it and break it into smaller fragments. And then after breaking, you started removing. So do you prefer to remove after chopping all the fragments or after any particular reason?
The reason is once you start removing one bit, the chamber becomes unstable because the PC starts coming up. So once you have made it into all small bits, then you can just stay in the center and start removing the bits. But if you do the opposite, you're going to have a very unstable chamber. So, I mean, I've been doing this all my life.
Okay, nice. Thank you, ma'am. We'll move on to the next talk, sir. I think the next talk will be on coloboma, that is by me. So I'll just start sharing my screen. Yeah. So welcome, everybody.
I want to say a few words about Nivian.
Yes, sir.
Nivian.
Yes, sir. Yes, sir.
Co-instructor, Nivian is probably one of the most dynamic ophthalmologists I ever seen. So there is a saying that genes cannot go wrong. Obviously, Madhi's and Shalini's genes have not gone wrong. In Nivian and Nishant and Pratibha and Shruti, they've done wonderfully well. And Nivian is probably on the top of the table as far as the young ophthalmologists in India is concerned today. And today also he is going to compete in the Think Under the Apple Tree in the finals. Wish him all the very best. And very, very innovative guy, very good surgeon, both anterior and posterior segment surgeon. And I'm looking forward to your talk, Nivian.
Thank you for those encouraging words, sir. So I'm going to talk on phaco and colobomata eyes. So as we know that colobomas can present in various presentations. So it can be just a simple iris coloboma or an iris with a lens coloboma. So that makes it a little more tougher where you have the flattening of the lens edges. It can be associated with retinal choroidal colobomas. That's when you have the small eyes. And I think Swamar has already told about when you have a combination of microophthalmia or nystagmus. So these are things that we must have commonly seen when we do eyes with coloboma. So I'll start off with the first simple case of an iris coloboma. So what all the precautions that we have to take when we start off the case? As you can see, the inferior iris coloboma there, but it is not a full defect. And also this relatively NS2 grade cataract, so it's not a harder cataract. So the rexis, we should always make sure to slightly inside because we have a tendency to go away when the coloboma site is there. For beginners, I would suggest we can even make a limbal incision like this. Because in case we have a problem, we can always convert it easily. But we should make sure that the entry is a square-shaped incision. A slow hydro dissection, as you can see, the fluid wave is not going as a jet as we do it in other cases. And also some amount of hydro delineation. So the phaco is, I think, the surgeon's choice. I prefer the stop and chop technique. The only thing here is, if you see, I'm trying to slightly bring the nucleus to the center and then initiate the chop. Because at that point where the zonules are weak, it can actually give away during the surgery. And the third point is, before coming out, always fill in with viscoelastics. So I learned this from sir in managing PCRs, but here also that area where the zonules are weak. So if it collapses, the vitreous can prolapse through those weak zonules. And during cortex aspiration, I call it the cortical stripping, because as routinely we are not doing an aspiration, because even during aspiration, some of these zonules can break. And after doing a good phacoemulsification, we can still lose the bag. So actually engage this cortex, strip it to the center. So once you're there in the central zone, then hit the aspiration of the foot pedal, and you can see you can aspirate the cortex. Since it was just a small segment where deficiency was there, we introduced the CTR. So there are various methods of using the CTR. I prefer just holding on to the eyelet of the hook and making sure I can see the margin and then release it under the margin. And choice of IOL, any foldable lens. But again, we make sure that the haptics are actually where the weak areas are. So that again gives some amount of stretching of the bag and prevents late complications like phimosis of the bag that can happen. So these are some of the small problems that we can face, like zonal deficiencies, pure dilatation, and accompanied microophthalmos. So moving on to the next scenario, when you have a bigger defect, and also you can see the lens coloboma, you can see the flattening where they're absent of zonules. Initial case, maybe they had weak zonules. So here again, of course, any case, getting the rexis right is very, very important, because in case we land up with complications, then we have other choices of keeping an optic capture or anterior or a posterior capture. So getting the right rexis, making sure you don't run towards the edge of the coloboma, because since the zonules are weak, it is very difficult to pull back the rhexis when it extends. So I use the forceps to stabilize the globe, and here we are making a clear corneal incision. And you can see this is a fairly harder nucleus, and I prefer the stop and chop technique for phacoemulsification. As you can see, the lens moving, and also the iris diaphragm opening up and closing. So these are some of the common things that you might face with any coloboma cases. I am using a little more higher energy than usual because in this there is a small compromise that I don't want to be pushing the nucleus too much, and that can cause further damage. And you can see I'm doing more of the trench only in the center. So as far as I get a good depth in the center, I can initiate the crack from the center, and I don't want to reach up to the periphery. Here again, the same principles of filling it up before coming out. Something different here, you can also use the two instruments for beginners. If you don't want to put more stress on the zonules using your phaco probe, you can just come out, there's no harm. You can use two Sinskis or one chopper and rotate the nucleus. Then going on to the phaco 2 mode, bury into the core of the nucleus, slightly lift it up, and then initiate the crack so that the stress is less. Since it's a leathery crack, you can do a multiple layer crack. So making sure the epinucleus cracks before you pull it, because in a hurry, if you try to pull it, so these are sticky cataracts also in colobomatous cases. So sometimes it can just come along with the bag. So once you have one piece outside, I think it makes it relatively simpler to rotate and remove the other pieces. And here you have these fibers left. So what I use is something called as a saline hydrogel. So another method of cortical cleanup or like polishing. So just inject fluid along the PC so you can even clear off those cortical remnants, because we want good post-operative results. So after implanting the lens, in this case, because of the larger defects, I think we can go ahead and do the single pass 4-throw pupilloplasty, which was invented by Dr. Amar Agarwal. I think it's an amazing innovation of iris repair techniques, because I initially found that the other iris repair techniques little bulky and cumbersome to do, but this was a very, very easy thing to learn. Just have to pass a 10-0 pro suture through the iris. You can see just holding it through the forceps, getting an initial bite, and then through the other side, you're passing a 27 gauge needle. So this has to be done in the site where you want the defect to close. So whether you want to go anterior or posterior, we'll have to make the choice. Now just railroad the needle inside the 27 gauge needle and then bring it out, and then form a loop from the posterior edge. And once that loop is formed, just bring it out, and then you pass 4 throws inside. And then when you tighten, you can see how the iris defect is closed. Because initially we were not doing this. There are some patients who complain of extra glare, and especially the edge effect of these lenses. But I think now we have a solution for that, and then we can do this, and the patients are happier post-operatively. So this was the pre-operative picture of the same patient. You can see the brown cataract, and you can see post-operative day 1 how it was, and eventually the patient was very happy with his vision. This was 1 week post-op picture with a few DM folds, because it was a slightly denser cataract. And this was 1 month post-operative picture, well-centered IOL, good overlap of the anterior capsular margin. The third scenario is something that we have a larger coloboma. You have already vitreous that is trying to come out. So I think this was published by Ashwin. I think his talk also has this. So it's called the vitrectomy-assisted phacoemulsification. So when, because of the fluid hydration, that some amount of vitreous comes out. So what they suggest is you can put a trocar and do some amount of anterior vitrectomy. So this not only clears the vitreous that is going to come through the defect, but also helps in deepening of the anterior chamber. So there is more space to work in these colobomatous eyes. So you can see the cutter there through the complete defect, because sometimes during the procedure, we see the vitreous coming and getting caught to the phaco probe. So once you do that clearing, then doing phacoemulsification becomes simpler. This was a larger defect. So this was actually a video borrowed from Ashwin. So they've used both the iris and the coloboma hooks. So thank you. So once again, I'd like to thank the entire team. And as they said, we've been doing this course for 3-4 years successfully, and hope to continue the journey. Thank you.
I think it's a very beautiful talk, Nivi, and very nicely covered. I just wanting to know from you, you have a huge experience with the coloboma of the iris, and what about lens colobomas? Have you seen any lens colobomas also along with that? Do you use any CTRs, number 1? Number 2, number 3 is because there was a lot of papers saying that by closing the colobomatous defect, you're not giving any particular benefit. In fact, many papers say that the patients actually see, because the the brain is tuned to that visual axis for them through the colobomatous area. I want an opinion from Samresh and Sujata on this, as well as Nivian so take on this.
Correct, sir.
Yeah.
So we commonly use CTRs because we don't have much experience with segment Sionius rings fixation. But as you said, with large lens colobomas, more than 180-degree subluxation, we have done cases of we have to remove the entire lens in toto with a lensectomy and place a gluediol, or sometimes I've even done claw lenses in these colobomatous cases. So as you said, initially we were not closing the defect. But I agree with what you said is if it is associated with the retinochoroidal coloboma. But sometimes it is not like that. It is only an iris defect. I think we can do the SFT because that creates that smaller aperture and the glare is less for the patient. But as you said, if it is a retinochoroidal coloboma, patients are already used to having a different site for vision because they use other areas of the retina and the visual stimulation is through that. So in those cases, we, as you said is rightly, we should not be doing this.
Vivian, I just saw a video from Dr. Harbhajan Singh. He himself has made something like what is this iris for the coloboma iris, and
Defect.
it can be clipped onto the
Kiranjit Singh.
Kiranjit Singh has made. Have you had any experience with this? So he is enclaving the that I don't know what to call it.
It's an artificial iris clip, Maria.
No. It's an iris claw which is colored. It's a cosmetic iris claw which is filling the iris defect.
It's filling the defect. So he's just like how we do an iris claw IOL, no? So he's just on the iris. He's just clawing. He's enclaving on either side of the iris. So he, depending on the size of the coloboma, I think IOCare is making it for him. So he tells him what size he wants, and they make it for him and give. Have you had any experience like that? It looks
really
no, it's not difficult because like people like Nivian, they're already doing a lot of these iris claw lenses. So it must be very easy for them. So it works wonders because like, the whole surgery is done so smoothly without any of these SFT and tearing and all that.
Sure, ma'am.
Into that.
Actually, I can pass on the Kiranjit Singh's videos there. It is also there in the Apple Tree, this thing. And it's really a fantastic video. And in fact, he sent it to me first as soon as he did one. And it's an iris claw lens, which is being fixed, and really fantastic innovation. And what do you do for coloboma, Samresh?
Sir, again, if it's a traumatic sort of a picture or traumatic coloboma, I would go ahead and do an iris repair. But if it's a long-standing coloboma like congenital coloboma, I normally would not touch the iris and fixate it because patient is used to it. Yes. And and I would avoid any extra manipulation than what is basically necessary. When it comes to coloboma, so if it's only one clock hour or so, I would leave it and go ahead and do just a plain phaco. But normally, what I would do for a larger coloboma is first thing I would do is triamcinolone staining, even before I inject viscoelastic in the eye, to look for any vitreous presentation, because all the turbulence can cause vitreous disturbance. And I would normally fixate or do at least a simple CTR if the rest of the zonules are okay. But if there's any zonular weakness that I encounter during the surgery, I would not shy away from putting a segment and tying it up with the sclera for extra stability.
How do you position the lens? You position vertically or you put...
Sir, if I'm putting a CTR, it doesn't matter to me. But if I'm not putting a CTR, I would put it along the axis of the coloboma in that case to strengthen and stretch the coloboma at that end.
But a very nice talk, Nivian. I think you covered all the aspects so very nicely in this particular thing. But coloboma is always very difficult, and every case, you decide on a case-to-case basis. What is the status of the posterior segment, as we rightly said, and the extent of the coloboma, and the duration of the coloboma. Is a traumatic coloboma or a congenital coloboma, and the presence or absence of any lenticular coloboma along with that, the presence or absence of any zonular pathology as well. So, and the density of the cataract, so many things. I also find that every time, because even during the live surgery, I asked you the same question, Nivian, you don't expose the tip of the phaco probe. What is the reason for that?
No, sir.
I thought we could expose the tip a little more.
After
Yes.
you said that, I noticed it in my previous videos, sir, and that's why I constantly learn from you. That is the reason why when direct chop, sometimes the nucleus piece was not getting buried and kept releasing. So nowadays I've changed the technique of exposing the little more of the tip, so that actually helps in doing a better chop also and getting a better hold.
Yeah. We have some time, no? Or shall we go to the last talk?
Yeah,
My
yeah.
talk.
Yes, sir.
Okay.
So I think
Shall
it's a
I
great
start the
and a privilege to be introducing Dr. Mohan Rajan, sir. I don't think so I can do justice even if I get 60 minutes of my session to introduce half of what he has done and achieved. And he's well known not only nationally but internationally. He's very well known for his excellent surgical skills, excellent teaching skills. He's also an excellent researcher, and he's already got his PhD also. That is very inspiring to get his PhD also. But there are certain things that set him apart from other great stalwarts. He's a great human being, and he's always been a leader. So what a leader does is always inspires others and also motivates them. So today I'm here conducting this session is entirely because of what Mohan Rajan sir has done for me. So I'm very thankful and grateful for that, sir. Thank you. So
Thank you, Nivian, for the nice words, and I'll be sharing my screen now.
So sir is going to talk about how to manage all these complicated cases with flax, the polar cataracts and the black cataracts that we are not touching.
Okay, I'm going to talk about, of course, black cataracts, all the cataracts. The previous session also, I was talking to Ashwin Agarwal, and I was talking about the use of the flax, which is not only for the black cataracts, complex situations, but any situation for the matter. So today I'm going to talk about the polar expedition, the black cataracts using the flax, the catalysts. Okay, these are the financial interests. What are the keys to the refractive cataract surgery? Increase the refractive accuracy by doing a good biometry and addressing the astigmatism, decreasing the complications like corneal edema and the posterior capsule rupture. Choose the best quality visual IOLs and exceed the patient expectations, under promise and over deliver. Hard-bound cataracts is always a challenge to the phaco surgeons because the difficulty to crack the nucleus because of the leathery attachments, the thin posterior capsule, large nucleus, poor or no cortical cushion, increase in corneal edema and postoperative corneal decompensation, increase in PCR and nucleus drop as well. So you need to combine the technology with the technique. These are the machines which are available to everybody, and these are the brown cataracts. It's actually like the piece of granite you can see here. Always look at the endothelium. Look at the endothelium. Make sure that the endothelium is very, very important before you deal with such cataracts by means of the phacoemulsification. If you do a manual phaco on this, probably you can have a corneal edema, or if you do a femtophaco, you can have a crystal clear cornea. I'll tell you why for this. If you have a corneal edema, the corneal edema may clear in about a few weeks' time and maybe a few months' time. But the problem is the corneal edema is associated with a lot of inflammatory mediators which are released into the eye. And you can have something like a TAS, which is called fibrin reaction. And as high as about 25 to 30% of the patients can have associated cystoid macular edema in the retina, which may be a difficult problem to solve as well. So look at this manual phaco quick chop express, what we call as, and I'm using the phaco power of about 60% and a vacuum of about 450 on a Stellaris Venturi system, which is Stellaris PC system. And you can see here I'm doing a Rexis. Always the Rexis is done with the means of a trypan blue. This is a manual phaco wherein things go very easy. I do a trench. I need to do a trench here because very dense cataract. These cataracts are as thick as about 5 or 6 or even more than that, 6 millimeter. And see how I'm trying to bury the tip and chop. I'm using my chopper, the Mohan Rajan chopper. I don't have any financial interest. You can see how much time it takes for me to open up the posterior nuclear plate. Repeatedly, I have to do it in multiple quadrants. And every time I do that, bury that, I have to, expend some phaco energy as well. So use some phaco energy, and which means that every time you use a phaco energy, there is going to be a direct transmission to the corneal endothelium, and that is the problem. And this surgical time also takes a little longer time. You can see the EPT in this particular case, despite the fact that I'm using a cold phaco technology, about 24.3 seconds. So what is this catalyst? This femtocataract, the manual phaco is like this. wherein you can, like it's like Sachin Tendulkar, the femto cataract is equivalent to Dhoni, I would say, because the Dhoni can play in all the formats, whether it is one day, T20 or the test. And that is where I think the femto cataract can actually, not only the complex situations, but also in softer cataracts, posterior polar cataracts, subluxatory cataracts, and everywhere, as long as the pupil does dilate well, you don't have to sing. In hard cataracts, I do a vertical spacing of about 25 and grid space of about 250, horizontal spacing of about 10, segments for soft spacing of about 200 microns, and pulse energy anterior 8 and millijoules and posterior about 10 millijoules. Rock hard cataracts, I reduce the vertical spacing to about 20 and grid space and all other things remain the same. So this to show you some of the this thing wherein you can see here, this is a fairly hard cataract. I'm using a femto platform. I divided the cataract already. The rexis has been done and divided the cataract into six quadrants, or what we call as the sextants. I'm using just as simply as Sinski hook to open up the nucleus because it's already pre-cut there. That is the biggest advantage of the femto. You can see here already there's pre-cut and it's very, very simple. I just have to go in and bury. We use very less phaco power and you can open up the nucleus this thing and then go ahead with the phacoemulsification without any problem because everything is already done for you and it just pops up into the phaco pore without any problem. Now and then I inject viscode for all these hard cataracts into the anterior chamber to make sure my endothelium is cornea is very crystal clear. You can see another patient with a little more harder cataract than the previous one. Just to show you, I'm doing the main incision as well, the side port incision as well. And in 70% of the cases, I do the main incision unless the patient has got a very dense arcus senilis, and 60 to 70% my main incision works very well. You can see here, once I do, we have to be a little careful about hydrodissection because already the gas bubbles would have done some amount of pneumodissection as well. And you can see here, straight away, I'm doing the chopping. I'm burying the tip. You can see my tip is a little bit exposed. You can see that air bubbles or gas bubbles are coming up. The very fact that the gas bubbles are coming from the posterior to the anterior, it means that the cut has gone all the way to the posterior nuclear plate. I don't have to do any trenching, any of this thing. I just have to just go in and bury, and then the pre-chopped area, I need to just have to do the lateral separation. You can see the gas bubbles again coming up, and it makes very, very life easy. Once you do that, because sometimes you can do octants, sometimes you can do sextants. I normally do sextants or octants, that is the 6 or 8 pieces. As I told you, now and then, viscode, I don't have any financial interest. And everything else, you can actually close your eyes and do the surgery and without any problem at all. You can see this is a nucleus and more nucleus, very little cortex is there. And let's say UPT is only 7 seconds in this particular case. Again, the rexis is free floating rexis, and in the catalyst, that is the biggest advantage. I stain the rexis, and then you can see here, these cataracts are very big cataracts, as big as about 8 to 10 millimeter, and occupying the entire capsular bag, as big as the thickness of the cataract as thick as about 5 to 6 millimeter as well. And you can see here the chopping, otherwise the chopping, every time you have to bury in a manual phaco, you need to go and chop and use the phaco. This thing here is already chopped. You can see here, I'm just doing something like a lateral separation, which is very, very simple. Using the second instrument, you can use a chopper or a sharp chopper or a Sinski instrument, or even a blunt instrument will do the work very beautifully for that matter. You can see that the entire process is over. I'm just gradually increasing the size of the density of the cataract here to make it lacing. You can see again another patient with the preoperative corneal guttata. Corneal guttata, you can see the counts are less than almost 1,000, and very severe corneal guttata, very hard cataract as well. This is an ideal indication for a femto flax because it makes life easy. This patient underwent a toric lens. You can see here, and the rexis is done already. And these corneal guttata, we don't want to use much phaco energy because already the cornea is compromised, and you don't want, especially in a hard cataract, you don't want to injure the corneal endothelium much more than anything. I'm using a Centurion mission in this particular case, and you can see here I'm doing using a chopper there and separating that. It's already, the chopping is done, the rhexis is done, the minimal hydro dissection you have to do, and the remote dissection is already done. You can see here the gas bubbles are coming out. The very fact that the gas bubbles are coming out shows that the chopping has gone all the way inside. You can see here I'm using a Sinskey hook here just to separate that and making the life easy for that. You can see that post-operatively the cornea is fairly clear. Post-operative 2 hours after the surgery, the patient had good visual acuity of about 6/9 after the surgery, which in the case of a severe cornea cataracts or a fuchs endothelial dystrophy, very, very difficult to get in a manual phaco as well. Day one, you can see again the patient is having a fairly clear corneas. Again, this is a very, very hard cataract, almost a brown, black cataract. This they did the live surgery and the surgical strikes last year in 2020. And you can see here I'm using a Signature Pro machine. Whatever machine you're comfortable, whether it's a Venturi system or a Centurion or with the active fluidics, without active fluidics, whatever peristaltic or Venturi system. You can see here I'm doing the octants here. So you can see that the whole cataract is divided into 8 pieces there, and it makes life easy. And you can see that I'm trying to open up the posterior nuclear plate with very, very ease, very, very little lateral or what you call the vector forces. They are the whole posterior nuclear plate already opens up, because the most important problem is this thing is the posterior nuclear plate, which is very leathery. And once the femto makes a cut there, and it makes it easy with your chopper to open up the posterior nuclear plate without any problem at all. And once you do that, you can see that you can now and then inject viscode into the anterior chamber, and the rest is history. And you can see it's so easy, and the whole thing pops up because all these things are already cut. Yeah, and it becomes very, very easy. You can see that these corneas, all these corneas are all hard cataracts, all very clear corneas on day 1, day 2, day 3. And you can see that clear corneas, crystal clear corneas, pristine wounds, no wound burns. And that shows that amount of phaco energy is very, very less in this. You can see the pristine wound in a very, very dense brown cataract, very, very difficult to see in this thing. Again, in a white cataract, just to show you, the white cataract, Argentina flag sign is a very major issue. But in white cataract, 100% foolproof method is the catalyst, the femto. You can see here again, I'm trying to, only thing is look for skip areas in a white cataract. Don't try to pull the rhexis. Sometimes you can have skip areas in a white cataract. And that's why you have to make sure that complete. Once the rhexis is complete there, and it is there, it's very easy for you to go ahead and do this thing. Many people say that the common misconception is that whether the white cataract femto will penetrate. You can see here, this is again on a patient with a white cataract. I'm doing a toric lens in this particular patient, and I'm doing the incision as well. And you can see this particular video. Yeah, you can see this. The rhexis is already done. I'm just doing the side port and putting just to make sure that the skip area, I'm staining the capsule, because I want to make sure the skip areas are not, because the white cataract, there is a possibility of skip areas. Don't try to pull it. You can have tags on these things, which can lead later to the posterior capsule tear. And you can see here how the white cataracts also, the femto penetrates beautifully. The near total cataracts, the white cataracts, you can see that how it's beautifully opened up. It's of course not all that hard, but it's gone all the way down, and it makes life easy for you to do these cataracts. So the take-home message is flax in complex situations. White cataracts, hard brown cataracts, posterior polar cataracts. One of the biggest advantages is that you will be able to, because you can have an offset of about 900 microns from the posterior capsule. The beautiful epinucleus cushion is there for you to do that. Subluxated cataracts, fuchs endothelial dystrophy, all these are very, very important. Reduce surgical time, reduce effective phaco time, more precision, clearer corneas at day 1, reduce complications, safety, precision, bladeless, consistency, wow effect, good platform for marketing, differentiation practice from others. And that is a reason why I think flax is not only important. The previous session, I was talking to Ashwin Agarwal because he was asking a question. I was telling that it is not only good with, even for softer cataracts. These are we call as NHNT, or neither here nor there cataracts. Very difficult to do a manual phaco because we end up in trouble. These patients come with the 6'9", 6'6" vision, and these patients, I think, the best way to go about doing a safe surgery, because these patients' expectations are very high, is to do a flax for them. So the flax has got definitely better indications, expanded indications than what you can imagine. Thank you very much for the wonderful opportunity, Nivian.
Thank you, sir. I think once again, that was a flawless presentation. I think shows the perfect combination of surgical skills and use of technology. I think that's what Rajan Eye Care always stands for. So you've done a brilliant thing. Question for persons who are new to this femto thing is, what they say you can either break it into 8 pieces or 12 pieces. You can have different programs. So what is your preferred choice? And
No,
why
it is 6 or 8 pieces.
6 or 8?
4, 6 or 8 in Catalyst.
Okay.
I'm not sure about the Lensex. I had to ask Samresh.
It's the same, sir.
Same. 4,
So
6.
when do you choose between the three?
No, it's a harder cataract. I told you, no, I'll do the 8 pieces.
8 pieces.
I do the 8 pieces. I used to do the segmental softening as well. The problem is if you do the softening, then the entire time takes more than almost 2 minutes. Okay. I don't want to keep my femtophaco time. That is, the time is approximately 80 to 90 seconds. That is what I keep. 90 seconds is probably my upper limit. What do you do, Samresh, normally?
So I'm not doing
softening also. Yeah.
Yeah, so we're not doing Lensex in Jaipur, but in Ahmedabad, when we do it, we're not doing softening at all. Sir.
You're not softening.
It's a lot more gas production. I don't know whether it will make any difference, and also it hampers the glow and the view in the OT. And I doubt if it adds any value to the surgery as such. So we're not using it.
Yeah. So initially we used to do the softening, but nowadays, after the initial few cases, because the red glow is gone, and another thing is it unnecessarily wasting femto energy into the eye, and it doesn't have any particular advantage softening. So the one thing is the cutting of the cataract. The posterior nuclear plate is cut. Because of that, all the other subsequent maneuvers and getting a rexis right on target is very, very round rexis is very, very important, and the size of the rexis is also important. I make about 5.5 in a very brown cataract like this, or 5.2 or 5.3. I normally make about 5. We hear about make it about 5.2 because I want a slightly larger, bigger space, because these are all bigger nuclei, and that is advantage.
I think
you can play around with this mission. That is the beauty of this mission.
And I think you were talking about using the Sinsky sometimes, but I think you should invent a new chopper for using it in these flax cases, like your Mohanrajan chopper, which helps in lateral separation and easier thing.
No, you can use anything for lateral separation. Oh, yeah, that is the advantage, because already it's pre-cut. Okay, it's like a pre-chop, the pre-chopper you're using, it's like a pre-chop. It's already
what experience with any pediatric cataracts or subluxation? Because that was a question that was asked.
Yeah. That's a I have, in fact, I can, I thought you were asking me to talk only on black cataracts. That's what I said. I have a huge amount of experience with the subluxated cataracts. The biggest advantage of subluxated cataract, I have done subluxated cataract, mature cataracts, immature cataracts. Advantage is that because subluxated cataract, what is the main problem in subluxated cataract? The subluxated cataract, the main problem is getting the rexis right for you, because there is no resistance from the periphery. That is, so there had to be a central resistance, a peripheral resistance, and then only your rexis may using. Especially go to the zonular loss area, that area where the zonular weakness is there, then you may have problem with the rexis. So you get the rexis right, you get the segmentation right, everything is right. You just have to go in, pick up the rexis, pick up the nucleus. Without even rotation, we can do. Posterior polar cataract also, I don't even rotate. I just pick up the rexis, I just pick up the pieces, it comes off straight away. Because if you rotate the posterior polar cataracts, then the possibility of a posterior capsule rupture is there. So all these things, you can play around subluxated cataracts, posterior polar cataracts. Small pupils is the only thing, but some people use Mulligan ring and go in. I don't do that, but I have my cutoff is about 6 millimeter. If I have anything less than 6 millimeter, I will not do flax. If it's anything more than 6 millimeter, because my capsular rexis will be around 4.8 or a 4.9. If I'm able to get that 4.8, 4.9, then I'll be able to sing. I've done some even about slightly less than 6 also, with a capsular rexis of 4.5. especially for IFIS, I would prefer this because especially when I want to make a wound, the triplanar wound is very, very important. The triplanar, you will not be able to get it in a manual thing. Whatever you do, you can do only biplanar wound. By this thing, you can do triplanar. Go this way, go up, and then dip down. You can do that, and which is very, very important. Longer tunnel, you can do that. You can do that, but in a manual, it's very difficult to do a longer tunnel, especially in all these IFIS cases. It really works wonderfully well.
Right, sir. I think I'm going to
We
ask.
have some more time.
I'm going to ask a news hour question to Samresh before going on to the next speaker. So Samresh, between Flax and Mohan Rajan sir, and I think Sujata Mohan ma'am is able to manage these cataracts without the use of Flax. Ma'am, your additional points on using Flax and what cases had made it comfortable for you since you're managing all these tough cases. How was it helped?
At the risk of getting fired by Mohan, I prefer to do all my cases manual. But in today's age, you have to adapt to this new technology. Yes, I do use them, but I really don't actually promote Flax. I think the one important use probably would be a mature cataract or a PPC. These two things, definite indication is there. But other than that, I think if a good, well-rounded phacosurgeon can do a Rexus in almost all the cases. There is an additional advantage when you have a hard cataract. A little bit of pre-chopping is done already by the machine, but I don't see it as a great advantage. Probably the only advantage I would say is a hypermature cataract or PPC. Those two are the patients
I think sirs made all the brown and black cataracts. We are talking about brown cataracts. Black cataracts doing such separation with ease and also protecting the endothelium. I think if you do your own study in your hospital, maybe you can show that you're getting better post-operative results and less corneal endothelial damage. I think that is
absolutely
is useful.
I'm talking
where many people avoid doing phaco. Actually, they turn to manual small incision cataract surgery. So that is the fear of losing the cornea due to corneal decomposition. But here, I think all his cases were mostly black cataracts, not brown.
Yeah, but you feel the chopping is going to worsen the endothelium because we are doing the chopping in the bag. We are not, and how do you think that's going to worsen the endothelium?
Amount of phaco energy used. See, yeah. Initial trenching, initial debulking, all those steps.
Debulking. See, in a black cataract, I will tell you, if you want to do a black cataract, you need to do a lot of trenching. Okay, before that you cannot chop. Okay, because these are all very, very dense cataracts, very huge cataracts as well. You need to do a fairly good amount of trench, and every time you trench, you have to use. In Sujata's talk also, she was telling about you have to use 80 to 100% phaco power. Okay, otherwise you cannot trench. You cannot. Otherwise you'll keep pushing the nucleus. So whereas in a femto, the advantage is that all these things are pre-cut for you. Okay, you don't have to do the trenching. You just have to go in and do the lateral separation. Very useful. I'm not saying no phaco power at all. Certain amount of phaco power will be there, but definitely the study what we have done is the phaco power is approximately 1/3 of whatever you're using.
Mohan, I'd like to take Samresh's opinion on this. Samresh, Dr. Samresh, are you there?
Yes, madam. Here only.
I just want to know, because you are in this institute where in one institute there is no phaco, femto, there's the other one has a femto. So what would be your choice? Would you, I mean, as soon as you enter the institute which has femto, you grab and you just go and do all your cases femto? Or what is your choice?
So, madam, I think this is a very catch-22 situation for me because, I have patients who come over here to me and they say, no, can we go to your Ahmedabad branch because there you have femto and here you don't. And I think I boil down to the fact that I push the patients, like you rightly pointed out, patients who have posterior polar cataracts, not as much mature, but if I have a hypermature or a dangling nucleus, something like that, I would probably push them for Ahmedabad. But polars that look difficult to chop and hard polars, I will definitely push off. Soft polars, I can still do a bimanual eye and take out. But wherever I feel there may be a possibility of a rupture, I will surely do for a femto. For routine cataracts, I'm not really, like you said, I still can manage with a good Rexus and with a normal routine phacoemulsification. So in my mind, the clarity for a femto is with complicated cataracts. For subluxes, interestingly, we are not using femtosecond in our both the hospitals. We are doing a manual surgery even now.
Okay, I think we'll just play Ashwin's last video also, ma'am, before.
Yeah.
Unfortunately, Lakshman could not be with us, but he sent his surgical video. So I'll just share the thing.
Share the video, and we have how much time we have?
10 minutes, sir. Is it
Hi, my
seen,
name
sir?
is Ashwin Agarwal, and
Yes,
my
yes, yes.
vitrectomy in cataract surgery.
Volume,
I
any
do have
volume,
financial interest which allows pertains to my talk.
Yes, ma'am.
volume.
Volume is coming.
Not very clear.
Some more.
And,
Some more
vitrectomy in
volume.
cataract become
I've
more and more
increased.
important.
1 second, sir.
I think we should
No, no,
remove
it's okay.
audios, videos, then only it become clear.
Remove my video. Okay.
No, your our
coming in the
How, sir?
last few years than it's ever been, because a lot of surgeons are becoming anterior segment and posterior segment surgeons to some level at least. So let's go through with this process. If you do see a communication between the anterior and posterior segment, something like in these cases of a coloboma or in case of aqueous misdirection, there's always some form of communication there. In these scenarios, you really have to wonder that on a 2D or on a slit lamp, they basically look very elegant and nice. But the minute you start doing cataract surgery on these patients, they do tend to behave very differently. And let me define the problem a little bit more. When you go in with a phaco probe, you're also pushing in BSS or saline. Now this BSS or saline goes into the vitreous cavity through that gape and starts swelling up the vitreous body, that thereby basically reducing my anterior chamber depth. And that anterior chamber depth shallowing causes a lot of problems, whether it be cornea or PC. Now, let's take this in real time. This is a very simple, small coloboma, which basically could have been handled without any issues. But watch me, I'm basically doing a simple rexis. I'm doing a hydrodissection. At this point, it's absolutely fine. The amount of BSS applied inside is not too much, and you're able to, look at the depth of anterior chamber you get as soon as you push in that viscoelastic. And as you prolong 3 minutes, 4 minutes into the phacoemulsification, this being a small pupil, you might probably have to be there for a little bit longer. In these scenarios, you really have to wonder, at end of this phacoemulsification, I'm worried that, look at this. The viscoelastic that I'm pushing in is not going into the eye, rather it is blobbing outside. And this is a very clear sign that there is an issue that is posterior segment based, not capsule or iris hook based, which is what happens once we see this. A lot of surgeons across the world, they start pushing in a more viscoelastic, which causes more tension, or they push in some iris hooks, or they put in capsule tension rings, all three of which will not help the scenario, because the scenario is bundled with an issue of posterior segment swelling of vitreous body. Now, the proposal which I have started and going to show here is basically I'm pushing in a trocar into the pre-placing a trocar and then starting my phacoemulsification. So when I do have my BSS inside going in and swelling that vitreous body, I can, and my anterior chamber starts becoming shallower and shallower. Now I do always have the option of just going inside, doing a simple dry vitrectomy for 7 to 8 seconds at 1500 cut rate. That's about it. And once I'm done with that, I can easily go inside and emulsify the rest of the pieces. And believe me, I can do this intermittently, which basically allows me the freedom and the space that I need. Look at this, the same case. All I did was pre-place a trocar and go in with a dry vitrectomy, completed my phacoemulsification safely and soundly. Please make sure not to vitrectomize too much, because just 7 to 8 seconds does enough vitrectomy to kind of give you that space. You can intermittently do it as and when required. Each time you do it, the seconds should reduce time and again. And watch me, I can keep doing this intermittently till I am through with all my nucleus, epinucleus, and cortical removal. Even if I have this issue when I am doing my IOL injection, like watch this over here, my intraocular lens now when it's going in will have, I'm doing this just before my intraocular lens is being placed, so that I have good deep chambers at this point of time. Now, mind you, in most cases, I don't do this so often. Now, Apart from that, once my lens is in place, I also, in these colobomatous cases, do close this iris defect with a single pass pupilloplasty, thereby giving me a really round, nice pupil. Now, watch, I'm basically passing the suture single pass from one side to pressure from behind. Intumescent cataracts also have been tremendously helped with this. So, three vitrectomy. So here's one of some of the risks when I was chewing with this thing, and I already had a rupture, and basically the rupture didn't extend. So the idea over here was there was a you sometimes feel that you can always push in a lens even though that anterior margin is extended, but in this scenario I was not so lucky. I really had to, I saw some vitreous come out because that extension just went ripped all the way through the posterior segment. And so in these cases I had to switch over this to a glued intraocular lens, which is not a problem because I always use a 3-piece lens in these cases, and hence it was easier. I did put an iris hook at the end of the haptic, if you see here, so that the haptic does not go falling inside. I do a complete anterior vitrectomy. Once my anterior vitrectomy is done, I basically do a handshake technique to grab the tip of that haptic. Once the tip of the haptic is grabbed, I can easily externalize both my haptics. Both my haptics are externalized. I remove all the iris hooks, make sure there is no vitreous in the anterior segment, and now tuck my haptics into the Gebel-Chariot's tunnel, and thereby stabilizing my intraocular lens, close intraocular lens. You might have issues, and this is the post-op day 1 of the same patient. Now, sometimes what happens is you want to be using capsular hooks. Why should you use capsular hooks? And when the coloboma is large, you sometimes have this issue. And I want to show you this because this is VAP, that is vitrectomy assisted phaco, going wrong. And I think I learned a lot from this video myself, not just the video, the case itself. So here I'm putting my iris hooks in place. I'm putting my iris hooks in place to ensure probably in hindsight, I might not have done that. Probably waited for the phaco to kind of, here it's trying to go down. Not happy with this. I'm trying to manipulate and bring this nucleus into the anterior chamber, remove the iris hooks, and then try and complete my phacoemulsification, which is what I'm trying here. Put some viscoelastic in that side, but still it was completely trying to go south. And in these scenarios, all I can say is that this nucleus comes out in one piece. And once this is done, I'm pretty much safe that the nucleus is not going to fall down. I put my iris hooks back in place, completely remove all the cortex, remove iris hooks being placing these 3-piece lenses, because it can happen that the haptic, one haptic, or all the cortical matter is removed. Make sure that you do your single. How do I deal with it? This is also called vitrectomy assisted phacoemulsification. I have published this before. Here are some of the advantages of vitrectomy assisted phacoemulsification, and just for your better viewing. Thank you very much. Here are my YouTube and Instagram. You can follow me, ask me questions, any of that.
Thank you, sir. Thank you, Rohit sir, Mahipal sir, Naveen Sharma sir, ma'am, Namrata ma'am, and Partha sir. And I think I'll always be very grateful to Dr. Rohit Shetty for training me as a fellow. And I think after almost 10 years,
I think we can close up the session.
Yes, sir. Any concluding remarks, sir? Just 1 minute we have.
Yeah, I think you want me to say?
Yes, sir.
Yeah, let me thank Dr. Partha for the wonderful opportunity, Nivian, and also for the very nice, as usual, very good program, very useful topics, very wide range of topics, covering from the hyperopia, the axial, the phaco in myopia, as well as in small pupils, and of course the flax as well, the modern technology as well. Everything has been covered beautifully, and all the speakers did a very good job. I'm sure there are good take-home messages for all the delegates who have attended this particular webinar.
Thank you, sir. Thank you, ma'am.
Thank you.
Always
Thank
a
you
pleasure
ma'am,
having
for the
you.
wonderful opportunity. It was, as usual, very exhilarating and very nice to watch your videos and everybody's. And it keeps us motivated. Thank you.
Thank you, ma'am. Thank you, Samresh.
Thank you, Niven. Thank you, sir. Thank you, madam.
Sujata, one was a sincere request and appeal to you. Please, catalyst is also your this thing. Please use the catalyst. Because you belong to Rajan Aikar and you're my wife.
Yes, session concluded.
This is totally professional. Don't
Further discussions. You're bang on.
Thanks, Sabrina.
Thank you,
Thanks a lot,
doctor.
Sabrina.
Thank you,
Wonderful.
doctors, for the wonderful session.
thank you.
Thank you so much. Hope you enjoyed.
Yes, doctor, definitely.
See you. Bye bye. Thanks.